Thank you very much for the invitation. Since we talk about reverses, let's see where can we use them. What are the other things other than calf arthropathy that this was designed for, and what's happening in the literature. So, as you can see, reverse is becoming more and more commonly used. It's starting to take place and take over most of our practice in surgery. Even for patients with arthritis, that we would think of an anatomic replacement, a lot of things happen in trauma, and you can see this in the graph, how the anatomic replacements are losing place in favor of reverses. Osteoarthritis now is the most common use of reverse. It's no longer calf arthropathy. And there hasn't been a very big change in that proportion in the last 8 years in the Australian registry. And I think it's the best registry to use to see all of those changes in our practice, because it's very well maintained and very accurate. And the big change is that we're starting to use reverses in younger patients. Even in my practice, we have had to use reverses in people that are 50 years old now. So it's no longer a replacement for old people with calf arthropathy. It's more commonly used in younger patients with osteoarthritis. But before we look into the differences, there are some basic steps that are exactly the same. It doesn't matter what kind of replacement you do, anatomic, reverse, hemi. You always have to have a proper clinical examination, assess all the patient factors, have appropriate imaging planning, and know the implants that you intend to use. Because each implant behaves in a different way, and sometimes you can create more problems instead of correcting problems if you don't use an implant that can correspond to your examination. So if we decide to proceed with a reverse, for primary reverses, tumor and rheumatoid arthritis have similar complication rates to revision arthroplasties. And then revision from many other procedures has a high risk of complication, may require special implants, or may need multiple stages. On top of that, if you look at the registry, there are indications like osteonecrosis, instability, but the percentage is low, so we cannot be very accurate when we're going to describe the differences. So I think what we'll do is we'll focus on reverse for calf arthropathy compared to osteoarthritis and fracture, because those are the big numbers, and that's the majority of the cases that we're going to be facing in our practice. So a reverse is always a soft tissue procedure. Even though we add metal, we have to make sure we balance all the soft tissue around our reverse. Otherwise, the outcome is going to be horrible anyway. And what are the biggest differences between a calf arthropathy, osteoarthritis, and fracture? In calf arthropathy, you don't have the calf. Especially the superior calf is almost always missing. If you do it for osteoarthritis, the calf will be present. So you have to manage and find a way to deal with the calf. It's better not to just throw away pieces of muscle or tendon that you are actually fine. And in fracture cases, the calf is part of the greater tuberosity. And the outcome is better if you manage to restore that part, and you reduce the amount of bone loss if you manage to fix it. The subscapularis is sometimes not present when you do a reverse, so you need to manage and plan for this, because you will have worse outcome if you don't. Whereas in osteoarthritis, the subscapularis is present. It may have a little bit of dysfunction, but usually it is there for you. Biceps tendon, another issue. Usually in cases where you have calf arthropathy, it might not be completely absent. And then teres minor is extremely important to be able to have external rotation. Teres minor is usually intact when you do cases of osteoarthritis. So external rotation or planning for tendon transfers and things like that are not such a big issue in those cases. So you see, most of the things we talk about is mainly soft tissue and balancing soft tissue around the implant and not the actual implant that we plan to use. And the axillary nerve may have palsy when you treat trauma cases. And you need to consider this because the failure rate of a reverse in a patient with axillary nerve injury is higher. And this is a schematic of what you may be seeing when you deal with all those different cases, and the things that you may need to plan in your mind before you open the shoulder joint related to soft tissue. but the bone is still important. So the proximal humerus in osteoarthritis and calf arthropathy is usually adequate. Whereas in fracture, you may have bone loss, especially in the proximal humerus, and especially if it is a comminuted fracture or a neglected injury. In those cases, you need to consider ways to compensate for that proximal humeral bone loss. The glenoid is usually the opposite. In fractures, it's always some form of a type A glenoid, unless it's a joint fracture of the glenoid and the proximal humerus, which is not very common. Whereas in osteoarthritis, and mainly in calf arthropathy, you might have complex glenoids, and you need to deal with it either with augmented metal blade glenoids or with bone augmentation and bio-RSA. And these are the main glenoids we need to consider. I just remind you what A glenoids mean. So when you deal with patients that have calf arthropathy, then you need to take all of those things into consideration, including this is a metal back augmented glenoid. Whereas in trauma cases, you may need longer stems, but your glenoid is not going to be that complex. It's usually an A glenoid, so you don't need to consider augmenting somehow your glenoid. One more thing that can happen is even in trauma cases, you may not need a long stem. So on the top, you have a case of a calf arthropathy, but on the bottom, you have a trauma case with a combined lesion of the humerus and glenoid bone loss. In that case, the advantage of doing a reverse is that you can use the head that is displaced as a graft, and then proceed with convert your complex glenoid to a standard type A glenoid, and then put a standard reverse, not a patient-specific or an augmented glenoid. If you have axillary palsy, can you do a reverse? Yes. There is slightly higher incidence reported in the literature of failure, mainly of early dislocation. But if you manage that, then you can still do a reverse to compensate for the injury. So what are the biggest problems we can expect? Cases for instability and rheumatoid arthritis have a higher revision rate than calf arthropathy. Fracture has a high revision rate in the first 3 months, but after that, things gradually settle down. And if you see here, the highest revision rate is in the instability, and that is where you need to be very careful to restore the balance around the joint. So if we're going to collect all of the data we have, we find that compared to calf arthropathy, there's slightly higher revision rates in patients that have large glenospheres when we do it for a fracture, or small glenospheres, less than 38, when we do for osteoarthritis. The fixation is not that relevant, but cementless implants have a slightly higher rate of revision in the first 3 months. The glenoid type is not significant. The revision rates are the same in all 3 indications. And the BMI, again, not significant after the first few weeks. Similar with the RSA grade, but young male patients have a high failure rate, especially in the first 3 to 9 months. And that is in conclusion. So pre-planning is very important. You have to prepare to restore all the soft tissue and the bone deficiencies. You have to be aware of the small differences. Young male patients, you always have to consent them for a higher revision rate. And revision will always have a worse outcome than a primary reverse. But in general, the 10-year survival rate is quite good. It's about 93%. So it's a very good procedure to plan for your patients. And at 12 months, and that's important, 12 months after the main procedure, the risks and the problems are almost the same for all indications. The first 12 months are the ones that are important. And we have to keep in mind that after 2 years, all reverses can deteriorate, mainly due to either patient age or deltoid impairment and deltoid fatigue. And with this, I'd like to thank you with an image from our new elective orthopedic center in Kent. Thank you.